I'm now going to pass it over to Jennifer Kiger from Harris County Public Health for the next session on building, rebuilding, and maintaining trust in pepper science across diverse demographic groups. Thank you all very much, and over to you, Jennifer.
Thank you so much, Kai. I appreciate all the words that the panelists said today and talking about the issues of confidence and trust in PHEPR science among different diverse groups. My name is Jennifer Kiger. Like he said, I'm the COVID-19 Division Director for Harris County Public Health in Houston, Texas, and I was also the Chief of the Office of Public Health Preparedness and Response. And I'm moderating this next session, which will pick up on what was just discussed, focusing on actual strategies for building trust in pepper science among and across the range of demographic groups. Each member of the panel brings experience working in different communities and on so many different types of emergencies. We have an amazing and interesting panel representing a range of experiences and expertise. So I will invite each speaker to share their remarks. Each has 5 minutes. And if you want any more information about the panelists, it's still below on the event webpage. So I don't want to take up too much time, but please enter your comments and your questions in the Slido below beneath the video player, and I'll make sure to try to get as many questions as we can. So with that, the first panelist is Laura Bogart, the Senior Behavioral Scientist at RAND Corporation. Laura, you have 5 minutes.
Hey, thank you very much. And next slide, please. Okay, so I take a social, psychological, and positive psychology approach and perspective around solutions and for building trust. And so from this perspective, mistrust can be thought of as rational, as a normal, adaptive coping response to social, historical, environmental context, ongoing and previous historical racism, and context of structural inequity. And from this perspective, then, mistrust can promote resilience and empowerment by catalyzing change at the individual and community levels when channeled effectively. So, for example, an individual patient may have experienced discrimination in healthcare and then have mistrust of new treatments. And these feelings might lead the patient to ask a lot of questions and be empowered to ask questions, get a second opinion, and to advocate for themselves. And on the community level, we've certainly seen this with COVID-19, where mistrust in government and in healthcare systems has led to the formation of community collaborations led by Black and Latinx individuals to address barriers to addressing healthcare and accessing vaccine. And also, it's important to note, as previous speakers have done, that mistrust moves and is maintained through social networks. And so key people in the social networks, formal and informal leaders, natural leaders who are well respected in their subgroups. So any solution uses these three things as a basis from the social psychological perspective. So next slide. So we've already talked a lot in this workshop about community engagement and how ongoing authentic community engagement and empowerment is necessary to building trust and for solutions. So I just wanted to mention this. I know it'll be talked about a lot in this panel as well. And also talking specifically about needs assessments needed to be done with community engagement to identify community strengths, areas of expertise, areas of information, but also areas of misinformation and distrust, and the sources of mistrust. And to do this, working with communities and understanding what would be acceptable messaging around public health, and also who are the leaders and who are the important subgroups that need to be addressed. And also providing resources and capacity building and transparent data and information as needed, for example, to understand inequities within the community within specific subgroups. But the bottom line is to let the community lead the way. So next slide, please. So I'm just going to talk about two strategies. Of course, there are many more, but coming from communities is positive framing. So having science communication, having positive message framing, and really tapping into the groups to which people belong, tapping into their pride around group memberships, and this empowerment message and a message of resilience. So having positive, clear, and transparent messages, channeling community strengths and addressing misconceptions or areas of low knowledge identified in a needs assessment, and also being non-confrontational, non-judgmental. We've heard before this morning about empathy, acknowledging the origins of mistrust, where people are coming from, and then offering this information that's transparent and clear. And also, I'd like to add holistic health promotion and is very important to talk about the community as a whole, the health of the community and the well-being of the community, not a specific disease focus, which sometimes can be stigmatizing, but letting people know we're talking about the whole health. And on the right-hand side of the slide is some messages from my own studies, as well as that of others, both in the US, among sexual minority men, as in Uganda and key populations, where people have told us they want to hear empowering messages around HIV prevention, and in this case, pre-exposure prophylaxis, that it's empowering, that it helps to protect yourself, your family, your community. So next slide, please. So as I mentioned before, social networks are key to spreading information, both information, misinformation, disinformation, as well as trust and mistrust. So we can leverage the power of social networks, both online and offline. And talk from this perspective, everybody is a leader. Everybody can be a leader. Everybody can be trained to be an advocate and a leader. And peer-to-peer advocacy can be very effective because peers can be credible with other peers and trustworthy. And also identifying informal and formal leaders in the network and different subgroups in the network that are important to each of those leaders, and social influencers, both online and offline. And so I'll close with two examples. One is from my work in Uganda, where we've done social network interventions around HIV prevention advocacy, as well as cervical cancer advocacy, where we've trained peer advocates on these positive messages that we've gotten from the community that would resonate around empowerment, as well as how to be non-judgmental, non-confrontational, and how to identify strategic social network members. So that would mean social network members, for example, who bridge two different subgroups in the network, people who can get out the information easily and spread it to multiple groups and people. And finally, I just wanted to mention the Botswana COVID-19 task force, which used a social media monitoring approach, in which they got out the message through social media as well as through TV. And they had an agile response and clear, transparent information informed by social media monitoring on the ground in real time, so that they could see negative valence messages and posts and misinformation, especially by social influencers who they had identified previously, and so that they could get ahead of the information and address it right away. So thank you. Those are my comments, and I'm looking forward to the discussion.
Thank you so much, Laura. Next, we have Michelle Andrazik, the Director of Social and Behavioral Sciences and Community Engagement, HIV Vaccine Trials Network and COVID-19 Prevention Network. Michelle, you have 5 minutes. Thank you.
Great. Thank you so much, and thanks to the organizers for the invitation today. So I just want to follow up on what Laura had said. We really embrace community engagement as something that involves everyone in our network. And our network is comprised of 70 clinical research sites on 4 continents around the country. So when we were asked to pivot from HIV vaccine research, which we have done since 1999, to COVID-19 vaccines, the 5 COVID-19 vaccines that were US government funded, it was a relatively seamless pivot because we have been working in communities, establishing relationships with communities for that entire time. And we really focus on our reputation of trustworthiness and building that reputation of trustworthiness through relationships with community that are characterized by bidirectional responsibility and communication. And we involve community from the very, very beginning. We have community members as part of our protocol teams. We use community-based participatory research approaches to ensure that community members are involved providing guidance and direction in not only our protocols, but in all of the materials that we are developing and disseminating in communities, and with any of our ancillary studies that we are planning. So it's really key to have community involved at all levels. And, I really, one of the things that I think has been forefront in my mind with COVID is that I believe that what we're seeing is not just about mistrust. It is truly about our reputations of trustworthiness. And so what have we as institutions, as researchers, as professionals in the field really done to build our reputations of trustworthiness? And, often people will point to some of the historical challenges that research has had. And I would also point out that besides Tuskegee, Henrietta Lacks, the Havasupai Nation, egregious behaviors on the part of researchers, many people in marginalized communities can point to something that happened to their families yesterday or last week or a month ago. And so not only are we contending with these egregious historical incidents, but people are living current day discrimination, biases, and challenges that they face in the healthcare system daily. So it's really critical that we ensure that we are moving forward in a way that is cementing our reputations of trustworthiness. And so, many of the things that we did, we reached out to all of our community partners who we had relationships from the very beginning, and asked them what we needed to do to address COVID, to make sure that our clinical trials were inclusive and diverse. And from that, we established expert panels, community advisory boards, and many things that are documented in a recent PLOS One publication that came out documenting all of that. And I just want to say that all of those efforts resulted in 47% of the people enrolling across our CoVPN trials identifying as BIPOC, which makes us proud every day. Thank you so much.
Thank you, Michelle. Appreciate that. So we're going to go ahead and move on to our next panelist. We have Christian Capo, the Health Equity Manager for the East Harris County Empowerment Council here in Harris County. Over to you, Christian. You have 5 minutes.
Thank you. Yeah, our name's a bit of a mouthful, but it is the East Harris County Empowerment Council. So we do a lot of empowerment work on the east side of Harris County. But hello, my name is Christian Capo, he, him, his, and I do health equity work in this specific part of the larger Harris County. This is a set of unincorporated areas and small cities that are around the Houston area, but are outside of Houston proper. So they're near the Texas Medical Center, but there is not a hospital in the region. There's few pharmacies and clinics. There's not very many grocery stores. It's an area with a lot of healthcare needs, but very little met resources. The population that I work in has a lot of different types of diversity, and we like to celebrate and appreciate all those different types of diversity when we do our programming. Some of that is diversity in ethnic makeup or immigration status or income levels, or some of my communities are more rural, some of them are more suburban, and it just look very different. So they need very intentionally different programming. Within the context of that kind of community, I have 2 experiences I want to share, and that should take up most of my time. But one of them is more on maintaining the trust that we've built during this time of COVID, and one of them is on rebuilding trust after we've let this community down so many times before. So with the work that I do in health equity, it's been predominantly focused on COVID-19 recently because of just everything happening that way. But because it's been so focused on COVID-19, I've been giving a lot of presentations on how to empower people to talk about COVID-19, or why they should get the COVID-19 vaccine, or how they can just feel more comfortable understanding and answering their questions. But I've also attached to that conversations about mental health resources in the community, and specific needs and barriers that this community faces. So I have this presentation that I'd like to give about the unique needs and barriers of this community, and I'm intentionally giving it to those with age diversity. I'm giving it to like students, youth, middle schoolers, community college students, high schoolers, and older adults and retirees. I'm giving it to those very, very young and very, very old, kind of empower and give skills and resources to a different set of the community that still has a lot to say and has a lot of voice in the community, but it's not necessarily what you might think of for a community leader. It's a group that's very, very ready to ask you questions. I get a lot of very insightful and interesting things from the youth who have this very, very different understanding of COVID-19 than the working age population that I sometimes talk with. And focusing on this intergenerational communication can maintain that trust and kind of help that trust continue along as the population ages or changes. Secondly, we have another type of disaster in this community. And when I was giving this presentation the first time, one of my attendants, I asked what was their like main health concern. One of them said that the area was too polluted and that there were people fishing from the Superfund sites or the highly polluted areas the EPA has designated are unsafe to swim in, unsafe to eat the fish from, but people continue to do this anyway. Areas with high need of pollution, but also areas that you need specific long-term, well-planned out programs to address. This population I work in also has a lot of refineries. I can actually see 3 from my office. So this public health disaster of poor pollution and poor management and unsafety in the green spaces has been a work in progress. Very little has been done for a very long period of time. There is very, very little trust because the solutions that are being done so slow and over such a long period of time that no one is really seeing any efforts. So a lot of my efforts have been focusing on things like rebuilding some of that trust through holding events in newly revitalized community parks and green spaces, or engaging in advocacy work with the political organizations in our community. And third, I'm trying to meet directly with the refineries to have them come out into the community and to give their opinions on the matter and let the community have their voices be heard, to kind of bridge the gap between those creating the pollution and those suffering from it. And that is the gist of my experience. I look forward to your questions, and I thank you for your time.
Thank you, Christian. Very insightful. So we'll just go ahead to the next panelist so we can get some room for questions and some more comments from the panelists after this last presenter. So next we have Matthias Valencia, Director of Office of Equity and Community Partnership for Public Health, Seattle, King County. Matthias, you have 5 minutes. Thank you.
Okay. Thank you, Jennifer, and thank you for the invitation today. I appreciated hearing from my fellow panelists and all your work. I'm going to go back a couple of years and really talk about actually the intersection of both the pandemic and racism and our declaration of racism as a public health crisis. In early 2020, we were faced, of course, with the beginning of the pandemic, which was disproportionately impacted Black and Brown communities. But we're also faced with an already existing crisis, which was the crisis of racism. Here locally, like in the rest of the country, we had a very strong movement for Black lives that was really putting some very serious demands on us as public health and in other institutions. As a result of those community demands, we, King County and Public Health, declared racism a public health crisis in June 2020. Our communities wanted the same level of attention and emphasis on racism as we were putting on the pandemic. And of course, one crisis, that of racism, had existed for a really long time. So since the start of the pandemic, we have had different strategies for working with communities here in our department. One approach has been to create these priority population teams in which we have our internal staff from communities, racially diverse communities, teaming up with specific communities. So we have, for example, a Black African-American group, African immigrant priority group, Native Indigenous, Pacific Islander, Latinx, Asian, South Asian. We have also focused on specific sectors like small businesses, plus specific populations like people with disabilities, LGBTQ communities. We use the concept of targeted universalism. We have universal goals, and then we have focused strategies for each population since they have each distinct strengths and barriers. So for example, we aim to get high vaccination rates across all racial groups and geographies. And then we've had different teams and partnerships with each of those communities. So that has been, for example, a really important contributing factor in us being able to reach 82% completed vaccination across all races for those 16 and over. With our declaration of racism as a public health crisis, we have focused on co-creation. I think this has been a theme already talked about with some other people today. It means working with our community navigators, coalitions, advisory group, funded CBOs from the very beginning, including in the design of programs and policies. Those partners are our leaders, our trusted messengers. And of course, we also just can't assume they're gonna do this for free. We have to invest in them and resource them. I think that one of the things that we hear commonly from community is accountability, and that's extremely important. They demand that of us. We have created a new accountability tool, for example, in our Pandemic and Racism Community Advisory Group. We basically, in that group, we take the lead from community leaders. They represent the steering committee, a supermajority in the group itself and in the steering committee. And we have worked with them on multiple policies from early on in the mask directive and have made very significant adjustments based on their input to then more recently when we passed our vaccine verification policy for businesses and other entertainment areas. And so basically the accountability tool is a way for us to report back to the group after listening to them. We tell them what we incorporated, what we didn't, and why we didn't incorporate the things that we didn't incorporate from their suggestions. I think another key tenet is transparency. We've been doing that also and aiming to do it across issues. For example, we are currently engaging our Pandemic and Racism Community Advisory Group in our budget, and as we develop our next biannual budget for 2023 and 2024. We're still early in that process, but we have done a deep dive with them on our overview of our budget and heard from them about priorities. Next, we're going to be going back to them and hear their ideas and feedback on some of the specific proposals that we have for the next biennial budget. We also want to hear from them what they most want to value and see in our investments. So, you know, of course, this work, as you work with community, it's hard. Early, we had a lot of distrust among community organizations, and we have developed some really powerful partnerships. We won't say that we've resolved everything. We have a long way to go. We continue to dismantle a lot of these systems that have caused harm and continue to build trust, which we know can be quickly broken. But really, what we say is when we're working with communities that have historically been harmed by systems of racism, I think the fundamental notion is also that we can only work and move and progress at the speed of trust, and that takes time. Thank you.
Thank you so much, Matthias. We had another panelist, but that panelist wasn't able to join us. So I'm going to take a little bit of time just to talk about our situation in Harris County. I've really appreciated a lot of the different conversations that we've been having this morning. And, you know, a lot of the things have been sticking out as things I wanted to discuss as well. So here in Harris County, we unfortunately have a lot of emergencies, whether it's hurricanes, floods, fires, chemical explosions, infectious diseases. It's one of those things that we're well known for, that it's not something to be known for. But, you know, we have hashtag Houston Strong. We are a more resilient community for it. And we also have a very diverse community. What I wanted to add to what they discussed was that we found out that during these emergencies, while they do unfortunately bring people together, and even though we wish we could prevent them entirely, we need to utilize these events to further our community partnerships and gain trust. So the time to act is now, if you haven't already, and it's to really work on it in between emergencies when you can. And we found that after hurricanes, you know, we did have a little bit more leverage or more funding as well to be able to convene groups together and to start make some actions to improve the resilience and preparedness of our community. And just the awareness sometimes of what they could do and what we can offer to help them in that next emergency. We found that it requires going directly into the communities and engaging in their cultures, their food, their faith, going into their house of worship, meeting with their, you know, faith leaders, and then bringing the community partners to the table. As you heard earlier, Venus was talking about it, and she works directly with our community. And I think the other part of it is admitting when we have failed as a public health agency and entity. Even for past failures from previous staff or even other levels of government, whether it's federal, state, or even local. We are a team in public health, and so just because it's not us that says something wrong, we have to work together and take fault for those things as well. And that's not always easy. We had a meeting where we were with community partners discussing the different things that we were working on, and we got a lot of people very frustrated with us because they were not brought to the table. And while we have plenty of excuses why we couldn't bring everyone to the table, that's not our response. Our response was that, I'm sorry, that wasn't good enough. And so we really learned that, as much as it takes extra time and extra work, and in a pandemic, we were all under-resourced, we're not doing a good enough job, then we need to work on it and fix it. And it's not enough just to say that we're going to work on it. To have that trust is to actually show action. And so we're really trying to do that a little bit better. And hopefully there's not another emergency, but unfortunately for Houston and Harris County, there often are emergencies. And working together is key. The other thing we learned is that resources are very scarce, and even in our community groups and our community leaders. And we're all in different areas of government and different areas of the community reaching into those same partners. And that wasn't really fair to them. They didn't have those resources. So really listening to what we could do to help them do their job better, because at the end of the day, that helped the community. And so we were able to provide some funding, but I think that goes back to what Matthias was talking about. It's just really establishing what is needed ahead of time so that during the emergency, we're not scrambling. And having the funds ahead of time would be ideal as well. And so one other thing I wanted to mention really fast is that internally to our health department, we had a lot of resources. And so one thing we did was we pushed out an email to our internal staff and said, do you have any partners, community groups that you're a part of that would want information on COVID, would want testing, would want vaccinations? I think a lot of times we look externally and we don't always look internally. And a lot of new partnerships were created because of that, because they're part of a faith community, they were part of a community group. And then all of a sudden now we were a trusted partner because that person was a part of that group. So I just wanted to kind of mention that really fast because it seems like a very easy one, but I think we often overlook it. And it was a great help for us here in Harris County. So I know we have a few questions that have come in. And one thing I wanted to kind of hit first was just kind of a follow up to Michelle and what she was talking about. One comment that was in the chat was, it seems like with some demographic groups, it is about rebuilding trust, so for instance, Native Americans, while others like white conservatives, it is about battling misinformation. All result in a lack of trust, but the root cause is totally different and require different strategies. Do you want to add anything to your comments to respond to that?
Yeah, I think that is an excellent point, and one of the major reasons why community needs to be involved early, at the very beginning and often. One of the things that we identified early in our work is the need to address data sovereignty and data ownership for tribal nations. And so we partnered with Dave Wilson from the Tribal Health Research Office to work together to get our protocol team leaders, investigators, together with tribal leaders and tribal nations to begin discussing data sovereignty and data ownership. And those discussions took a while. So if you look at the participation across the US government funded COVID trials, you'll see that there's a huge increase in Indigenous and Native participation in the Novavax trials and all of the subsequent trials. And that is when the data sovereignty agreements were finalized. And so I think it's actions like that to, again, making sure that community is at the table from the beginning to identify potential barriers and what is needed to address some of the historical untrustworthiness of institutions. And I think that that really is key. Another example that I can give is, our partnership with the National Medical Association and the National Hispanic Medical Associations, where we work together to curate town halls and listening sessions. And those were informed by some of the fears and the skepticism that we were hearing from Black and Hispanic, Latino, Latina, Latinx communities. And those were incredibly well received. And basically, the content was having community experts talk about COVID, talk about some of the misinformation and disinformation that was going around. And then finally, we are housed here in Seattle, Washington, and the Washington State Department of Health worked with us to go on the east side of the mountains, which is largely rural and farm-based, lots of ranches. And we worked together to identify leaders from the conservative community over there that would sit down and provide testimonials of why they thought the vaccine was important, what some of the misinformation was that was going around. And together with Governor Inslee, we were able to broadcast several commercials to that largely evangelical conservative community, and we saw an increase in vaccination uptake, and acceptability. So yes, it's incredibly important to work with communities and make sure that they are at the table from the beginning, so you can identify some of these challenges proactively. In the case of the evangelical, I'll be completely honest, we were totally taken off guard on that. We had not prepared for that. And so that was very reactive. And in that reaction, we made sure that we reached out to community right away to find out what needed to happen to move forward.
Thank you, Michelle. Another question we had was, do you think that communities need to have trust to act? And I'd like to turn that to Laura perhaps and Matthias and see what you guys think.
Yeah, thank you. Very good question. Yeah, I do think communities need to have trust to act, and it's about where they have the trust. If they have trust in their own community and their own leaders and their own people and respected people in their community, that can lead to action. There might at the same time be mistrust in other systems in the healthcare system, but I think there needs to be some trust in some communities and some in their subgroups in order to prompt their action. So thank you.
All right. Matthias, do you have anything to add to that? And then looking at different communities and different emergencies?
Sure, I will. I think among themselves, communities already have trust. I think part of it is thinking about what the role here of institutions is, and if there is a role. And I think sometimes there is and sometimes there isn't. I was always struck by just some of the stories of resilience in our community. Some of our Native Indigenous communities moving to quickly like virtual powwows and doing all kinds of great activities here locally. They actually did an amazing job vaccinating, getting very high vaccination rates. They actually were leading our county. I think in those kinds of situations, we also have to think about trust means something quite differently. It actually means getting out of the way and being able to know when to support, how to support, and kind of be there when they need you for the things that they need you. But in that case, the communities know what they need to do. And then sometimes, trust is a goal, and it's something that they are going to rely on us for. So I think it just needs to look really different. But I just think also working from an assets-based approach, just understanding all the strengths that communities have is extremely important, and not going in with a sense of you're actually going to be fixing things, because many of these communities have been able to be resilient and do things on their own despite the things that government has been able to do.
Thank you, Matthias. So another question we have is for you, Christian. What does your approach look like when talking about a chronic emergency such as Superfund sites versus an acute emergency like a hurricane, which we have both here in Houston?
Yeah, I was about to say, it's a very good question for Houston and Harris County. No, I think that's a very good question. Whoever asked this, I really like that because it is a very, very different approach. And I think part of it comes down to like the optics and the visual, where like an acute emergency like a hurricane, you see a lot more of the destruction more transparently. It makes it a lot more in the news. It's oftentimes a lot bigger scale versus these long-term emergencies like a Superfund site. It's causing a lot of pollution and death and disability and problems for the community, but over such a long time frame and something that is sort of like less seen, less publicized, less easy to like point to. And that's why it takes so much longer. It's so much more ingrained. It's a lot more moving pieces than let me rebuild, let me get people the supplies they need. It's let me infrastructure change and cleaning and removing hazardous waste and education and treatment for the community. And it's just so many moving parts that oftentimes are relegated to behind the scenes that it's harder to talk about and build trust with because a lot of times people don't know that these things are happening or they don't know how far along any of these programs are. They don't know how far along the Superfund site is. It's not really common knowledge for those in the community, even though this is something that they're all struggling with. They don't know when it's going to be better, so they kind of just, whatever, it's going to be bad forever. I'm going to be dealing with this forever. That trust is lost because it's not being constantly reobtained and recommunicated.
Thank you, Christian. So this is a question for the group, and during an event, we know that trust fluctuates. So what are strategies for rebuilding trust in the middle of a crisis or an emergency?
I can go. I think, showing up is really key. And, I just piggybacking on what Matthias stated. I mean, Matthias and his team here, and I'm going to toot your horn, Matthias, because I feel like the Seattle and King County Public Health Department did such an amazing job of really partnering with communities to try to identify like the strengths that community could bring to the table and the strengths and the resources that Seattle King County Public Health could bring to the table. They recognized early on that uptake of vaccines was really low in South King County, which is where a large majority of BIPOC individuals reside. The large majority of BIPOC individuals reside. And we're able to quickly identify community organizations that had the resources to stand up vaccination sites and, provide the vaccine, provide the resources that were needed, and let the community do the rest because they had the relationships and they had the resources. And I think it's really critical to go, to move forward in all situations from a strength-based perspective and really looking at what the community has already in place and not trying to reinvent the wheel, and then letting the community lead it in the way that they know is best. And, because of that, we saw, increase in uptake and vaccination across South King County. So, bravo to Matthias and his team. You did a great job.
Well, I can say actually, Michelle, I have also been in awe on how you work nationally, but then also get involved in very specific communities. And I've seen, your organization and you in Kent and other places. So appreciate everything that you're saying. Also, I think you said something about showing up. I think that is so important. I think, and I'll just name it, kind of dominant like culture and even, often what we call white dominant culture, and there's a system of more control, top down. I think to do the equity work and the racial equity work, you actually have to show up and be in very uncomfortable situations, be in front of community when you are going to be really criticized for things that have happened. And one of the biggest challenges I often find with some colleagues, and this is where I also do some coaching, is it's not personal. It's not about you. It's about the institutions, it's history. So you actually are representative of an organization. You're coming in, you have to listen and take things back. And then you have to start to rebuild that trust, which means actually acting on the things that you have heard, reporting back. So not just going into a community, extracting information, and then not coming back again. There's a relationship that can be rebuilt through actions, and it's very intentional work. And it just, doesn't happen by, not doing anything. It just actually have, and that's why I was mentioning our accountability tool, because that's actually now beginning to formalize a process that we are already starting to do, but it's important to really be transparent around this and show that you actually have a process for getting back to community.
So there's another question we have. One of the ones that I'm pretty interested in as well is often trust is aligned with increased communication. So working with and communicating with your partner or with the community. And with so many diverse groups and partners, what's the best way to do this, either before an emergency or during an emergency, so that you're not just on calls over and over again the entire day? Matthias, do you have any insight?
Yeah, I mean, I can start with this one. I also think, there's not one size that fits all, right? So this is why we kind of also work with our communications team and all of that, but then we have different groups focus on different communities, and it's going to look different for each community. We've been able to, translate, and we have a language access, and we have about 140 contracts with community translators and interpreters. We are translating up to over 40 languages, but that's just part of it. You need to also, how does it get delivered? Who's delivering the message? How you are doing those things. So I think having, and it is resource intensive, but actually having a system to be able to really be tailored to each community is really important. And trying to actually, when you get one message out to everybody, assuming that that's going to be read by everybody and digested by everybody, like for us, our community navigators, which is a new program now that we have the pandemic, they're key, because we're not going to be able to reach, the Black community, the Indigenous community, with the same level of trust as people from those other communities.
Thank you. Okay, so another question we have is, we've talked about individuals' identities, whether it's racial, ethnic, gender. Does anything look different when talking about intersectionality of identities and trust and strategies that we take? Anyone?
I guess I can start with that. Intersectionality is interesting because, it really is individual, and it depends on, what your identity is and which identity, is predominant in a given situation. We could go into a whole thing on intersectionality, but I think the key is to have diverse representation. We were talking about communication, and communication can't happen unless people are at the table. So you need to have processes in place that ensure that a diverse and representative, inclusive community is at the table. And so, how are you doing that? What do your processes look like? In our network, every single one of our clinical research sites needs to have a community engagement plan, and that plan needs to be updated every year, and they need to update that plan in partnership with the community advisory board. So it's not just the site staff that are working on the community engagement plan, they're doing it in partnership with the community advisory board. And part of that plan is, how are you ensuring that community is having input, and that this communication is happening, and that whatever you're doing, you're getting guidance and direction from community. And that is really, really key. And in in doing that, I mean, in our HIV work, which, you know, transferred over into our COVID work, you know, there's so many, you know, issues with intersectionality in terms of gender and sexual and BIPOC identity. All communities that are most impacted by HIV and by COVID, and a lot of other diseases. I mean, it's no coincidence that marginalized communities are the most impacted whenever there's any disease. I mean, there's a long history of why that is our reality. So, you know, just ensuring that whatever you're doing is working to address those communities that are most impacted, I think is going to largely address any questions of intersectionality.
You know, maybe I will also add, thanks, Michelle, that, you know, communities don't actually see some of these categories as separate, right? And you know, we say that we lead with racial equity and racial justice, but that's an end to then be able to actually do work that's intersectional. When, you know, if we look, Michelle talked about like in King County, South King counties, where we have some of the biggest inequities, but then we begin to break it down. It's also, you know, it's not just people of color, it's those that people with disabilities. So it necessarily has to include also, you know, trans, queer folks, LGBTQ. It's a must, right? And then we also try to, for example, in the process of hiring now a disability justice position, but we want that person to have a racial equity lens. We need that. So I think sometimes talk about things in a way that is a little bit siloed, but I think it's because you know, we sometimes have to organize ourselves that way, but actually in practice, it has to be intersectional.
Yeah, and I just want to raise that Venus brought up a really good point in the chat to me that, you know, any community advisory board needs to have grassroots and faith-based representation. And I think that that is spot on. We have in our network a faith-based initiative, because we have seen firsthand how important it is to have faith leaders as the trusted messengers in many communities and across intersecting identities. It's very key. So I just want to bring that up, Venus. Excellent point.
Michelle. So another question we have is, what resources or research or other things would you need or are you looking for to help make you have your work go better in the future? Are there any challenges or barriers that you need help in overcoming when it comes to building trust in your community? So I turn it over to Laura or Christian to start off.
Sure, I can start. I like this question a lot because something that I have been struggling with is with our community being so many different diverse perspectives and backgrounds and stories and ethnicities, and every sense of diversity is being met. It's constantly being told that you're not from my community, you won't understand me. You won't understand what I'm going through, and just like, I don't have that lived experience and I don't have that close level of connection with the community. I remember someone from one of the previous presentations today had mentioned the same thing, like, in order to truly understand us, you have to live here for 15 years. That's not a thing that I am capable of doing. Even when I'm new to this role, even if there's trust in healthcare, there's not trust in me, and there's not necessarily trust in my organization. So I think getting that connection with the community is very important. And another barrier is that not everyone in my agency speaks Spanish, which is an incredibly needed tool when you work in Harris County, because so much of our population predominantly speaks Spanish or prefers to speak in Spanish. So not understanding the backgrounds and not having the appropriate language, both common like language about healthcare and health literacy, but also the physical language of speaking Spanish, puts a lot of our work and a lot of our staff at a barrier where we just like can't connect to the community and we can't build that trust no matter how hard we try. And it takes us a lot of time to get there. Not an easy answer, not an easy fix, but just something that I've come across as really being something I want to work on and something that our community needs.
Yes, and I can just add that and from the research perspective, just needing more data about these different subgroups and intersectionalities. So knowing where the inequities lie and what needs to be addressed within each sub-community. So sometimes we get we see data that's just the community as a whole or one group as a whole without these intersectionalities. So that's very important. And then from my own perspective, also doing qualitative research. So listening to stories of people from different groups, from different subgroups in the community is really essential to understanding what's going on. And I agree, it's what you really need to do is live there and work there, like somebody said, 15 years, but by getting these stories and getting data and then kind of keep asking what more can I learn without imposing anything is the important thing from the research point of view.
Yeah, and I'll just chime in. I think one of the biggest barriers is that so many people have unmet needs. We're talking about, over a century of housing and employment discrimination that have negatively impacted certain populations. And they're dealing with the challenges of those realities day to day. Here in Seattle, we have an incredibly challenging housing instability situation that we've been working, with before the pandemic hit, and it's gotten worse since the pandemic. So we have more and more people living unhoused that aren't having their basic needs met, and haven't been really able to resolve that challenge. And that is really going to continue to fuel the inequities that we see. And until we have, in my mind, I think the big elephant in the room all the time is how are we going to correct all of the negative health outcomes that have happened because of housing and employment discrimination that continue to persist. And that will continue to ensure that we see the inequities and the disparities that we are challenged with day in and day out. So I feel like we have some major public health hurdles that we have to overcome, and some challenges that we need to mitigate as a society to address many of the inequities.
Thank you, Michelle. Great comments by all of you. So I think we have one more question, and then we'll go ahead and close out with some closing comments from all of our panelists. So the last question we have is, how do you determine whether the science or evidence is trustworthy? What are key characteristics that you look for, or that you think the diverse communities look for to determine if it's trustworthy?
Well, I don't want to monopolize the time. I've thought about this a lot because one of the challenges with COVID is that SARS-CoV-2 is a novel virus. And we're constantly learning new things and constantly trying to, convey that information in an ever-changing landscape, knowing that the more the story changes, the more confusion there's going to be, and the more, disconcerting it is when that information changes. So, I think that it really underscores the need for us to be more trustworthy, and in doing that, being transparent. One of the things that we've tried to do throughout this entire pandemic is say, this is what we know to be true now, based on the information that we have. Things are evolving, things are changing. As we get more information, we've got these studies going on to try to identify what's going on with long haul COVID. We've got these studies going on to see if we need boosters and how many boosters we're going to need. I mean, the whole booster thing right now is so confusing to so many people. And part of that confusion is that we don't know what we don't know. And, we can only go with the data that we have. And that's what's exciting about science for those of us who are in science, but it's also the number one source of frustration, I think, for a lot of us, because We can only say what the data tells us, and sometimes we don't have the data. So, I think we need to be honest about that and be completely transparent about what we do know and what we don't know, bottom line.
And one thing I wanted to add to that, I feel like a lot of our communities, they get their trusted information from their family and their friends and their loved ones. And I think that makes sense. I mean, I think all of us probably do the same, but it's something very specific for COVID-19 where, social media, et cetera, there's other areas to get information that may not be necessarily trusted, but they're hearing it from a trusted person. And so that was, I think, a challenge that unfortunately we haven't figured out how to fully overcome that. But I think and I've mentioned this in other forums, and really it just would love to have a resource to where we are working across the nation on just similar, words, messages to the public. When new things come out from CDC or the White House, it's communicated in a more seamless fashion. And I know it's an emergency, so it's not pointing fingers. I just think that the more that we can be on the same page, the better it'll be. And then when they're getting information from various areas, it's at least in the same ballpark, unlike what we had seen. And so really addressing the misinformation as well is one of our big roles in public health, and really kind of a fine line between telling someone, hey, what you heard was wrong, because that's not the way to make it happen, is, that's their loved one that told them that. So really factual information and just becoming that trusted source and really being out there in the media and saying what you do know. So I agree with what you're saying, Michelle. Anyone else have anything on that topic?
Really briefly, because actually I've seen Michelle do this and we try to elevate this as well. I mean, part of it is also highlighting, like in terms of Black, Indigenous, people of color communities, also women in science, and they have been part of much of the work, research, for example, Michelle, other people, right, who are part of the process. So I think showing that, highlighting that, elevating that, I think is also really important.
Yes, and I agree. I was going to say that same point, that highlighting who is involved in the research on the team, how the research came about, if it was community-based, community engagement from the start, and also who's in the research. So is it representative? And so I think as a basis, for example, when I present research, I know I need to say those things, and that makes it more credible and trustworthy. Or if I don't say those things, those questions will come up, and they're very important to address. So thank you.
Thank you. So I know we're about to hit our time. I just saw something that came in the chat about what gives you optimism that we can bridge our communities and trust. And I really think that's a good way to end this. And so if you guys have any closing comments or anything like that, we have about 5 minutes left total.
Well, I can say, I think that one of the silver linings, if there is one for COVID, is that people who make funding decisions, who are, steering the ship, if you will, have, I think, gotten the memo that community engagement has to be front and center. And I think that if we are going to successfully sort of bridge all of these issues, we need appropriate funding to do community engagement. And community engagement needs to be centered as part of everything that we do, all, across science, across public health initiatives. And so I'm hopeful. I see a lot of movement in that direction, and I'm hopeful that that will be our new reality.
I can go next. I'm pretty hopeful since I do a lot of work directly with youth and have them asking whatever questions they have about COVID. I'm feeling pretty optimistic in the fact that they are feeling comfortable asking some of these questions, and they are seeing movement in getting those questions answered. And we've had several people who said, okay, now I do want to get vaccinated. Oh, now I do have, I feel less hesitant than before. Or we ask a question at the end that's like, what would motivate you to get vaccinated? And almost everybody says, I've already done it, or what would motivate me is my family. So this is a good highlight that, like, okay, we are doing the right thing. We are focusing on families and youth, and that's definitely moving our metrics forward. It's good to see.
Yeah, building a little bit on what was said, even Christian was just saying, I think, when we started and before vaccines were released, some of the early pollings just showed the level of distrust was, it was bleak. We even had some people in our department saying, should we even do anything, right? And from us who are from some communities of color, we're like, well, we have to do something. We can't just ignore it. So the fact that we have been able to achieve so much, I think, has been really a silver lining. But the other part is, I think we are in a critical moment right now. We are, funding is, for many areas, it's going to diminish. We need to think about how, and if we're talking about relationships and trust, how do you maintain those with less resource and then also kind of influence the larger structures and systems. For me, for example, working with we've been working with the whole department, but really making this a culture, not just of a particular office or section, but of the whole organization, and really integrating the things that we have learned into how we conduct our work on a regular basis. And this can't be a lost opportunity. And also, I think our communities have higher expectations of us now, and we've been starting to deliver. And I think going back or not using this moment for actually more transformational work within our organizations is a huge lost opportunity.
Thank you so much, Matthias. Laura, did you have something really quick you wanted to say?
Just quickly, I agree with all that's been said, so don't have much to add, just that it's great that it's now a national dialogue around community engagement, around racism, structural racism, discrimination, and mistrust and trust. And before we didn't have that as much, and I think now that will lead the path to more solutions. But thank you.
All right, well, thank you again to all our panelists, and thanks to the public for all the wonderful questions that we received.